former program director for the postgraduate education in the Department of Anesthesia at Western Ontario, Canada. Dr. Arif is going to talk to us this afternoon about, mainly this topic is going to be about the role of residency program committees. So Dr. Arif talk will be developing and operating effective residency program committees. So it's yours, Dr. Arif.
شكرا جزيلا والسلام عليكم مرة ثانية. This time is a little bit different. So this morning I talked about the global picture and how you see the postgraduate medical education and all the stakeholders. But now we're going to go specifically to one of the main stakeholders and try to dissect the job of the different smaller stakeholders inside. And this is where the work, the main work, when it comes to the residency training, interaction between residents and teachers, and how it's monitored and how it's ruled, and it comes down to this committee. So if I have to choose one stakeholder and you need to invest in it, it's the residency program committee. So the objectives is we're going to talk about how to set up an effective committee, and then how to run your meetings, and the communication within the committee, the program director as the committee leader, and I'm going to give you tips on how to develop your program. So I've been asked to cover these subjects. You will notice there is a lot of overlap between the afternoon sessions and the last session from the morning, because we're all covering a little bit different sides, but we intersect sometimes. So I'll do my best to cover those in the 20 minutes I have. In terms of structure, whenever you start any committee, you have to ask yourself a few questions. So first question, what do you need the committee to do? So it has to be very clear. You don't do committee just because you want a committee. So it has to be very clear, the goals and objectives of the committee. The second is, what sort of structure is needed for the new committee? How do you see it? How you envision it? What are the parties and the groups that should be represented within this group? So you can't just pick because you like people, or there's a good person, you have to choose them there. It has to be very clear. The third, to whom should the committee report? So it has to be very clear who, especially the program director, who they should report to. And the fourth question, who should I select as the chair of the committee? And you heard from Dr. Saoud, and I think you will hear in the next two speakers that the chair of the committee, when it comes to medical education or residency program committee, is the keystone, is a key factor for the success of the committee. Although it's a teamwork, although it's a group work, but I think the program director is doing more than 70% of the work when it comes to medical education. They're hard workers, they should be enthusiastic, they should be creative, and they have passion when it comes to medical education. And then whom should I invite to join the committee? So take your time, invest in the selection process. And question number two gives you a hint who you should choose. So the structure, if you want representation is from the subspecialties, for example, then okay, go to those subspecialties and see who is the right person to contribute with. And I usually think of it like a home or family, and who you need to live with, because there will be differences in opinions, there will be stressful times, there will be differences, and you need people to understand each other's. And it has to consider the accreditation requirements, because at the end, when the accreditation committee, they come to accredit you, they will see if your structure has met the requirements. I'll give you an example. So the B standards, B121, says that your committee should have representations from each participating site. So if I have in London, Ontario, I have 3 sites, so I have 3 representatives in the committee. It's a simple thing, but it can look bad if you don't have representations in the committee when the accreditation comes. Standard B122 includes representation from the residents of the program, so you have to have residents in the committee. And I think the minimum is 1. So, but most of us will have more than 1, depending on the size of the program. So, I have a PGY 4 who is a chief resident. I have a PGY 3 as a senior representative and a PGY 2 as a junior representative. So I have 3 residents. And the reason is because it's a big committee. I'll show you the structure. We have about 14 people in addition to myself. And I needed the residents' voice to be stronger in the group. Choose carefully, balance the group. This is mainly especially it comes to personalities and experience. So you don't have the entire group to be juniors, and you need this the seniority. The people can bring wisdom. Although we have to balance it, because one of the committee rules is you have to refresh it to keep it going. But we probably change people every 3-4 years. Although I have one of the members, he's been in the committee for 10 years, but he brings something different every time and keeps the balance between the different parties and mentor the junior groups. So it's very subjective. And again, I repeat this, try to balance the group. Make sure that the residents, they are not overnumbered. In the number, they are, but when it comes to opinions and decision, you are the one who will direct the discussions and decisions. Now, again, this is just an example. You can shape your or design your committee the way you want according to your requirements and your what the Saudi Commission or whoever is looking after the training they want, what the accreditation requirements. So this is myself, and then I have representations from all of these parties. So I have an associate program director, I have a program administrator, I have a site reps, 3 of them. London has 3 hospitals. I have 3 residents representative. I have a simulation and IT representative. I have a fellowship coordinator. We have a big fellowship program. We have about 22 fellows, and we fear the overlap and the interference with the residents' education. And actually, it's one of the accreditation questions is do fellows interfere with resident education? So this way, at least we can show the accreditation group that we really work hard for not to have that. I have the chair chief sits in the committee, okay, but he is non-voting member, so we need him to listen to all of the issues and help us because he knows the bigger picture. Research representative, and eventually we added the CBD lead, competency by design. As we move, we fear that we cross lines between the 2 groups, the CBD and the traditional cohort. So having them in the committee, they watch if we're doing something can interfere with the CBD group or the CBD group are interfering with the other group. However, that's the simple structure. And because there is a big challenge was coming into, which is the CBD, and we knew that since 2014, so we decided to be ready for the 2017 years ahead by recruiting more people and give people sense of what's coming. So we knew at that time that evaluations will be a key when it comes to competency-based medical education. And we knew that academic mentoring and advisors are also important in the group. So we designed these 2, and we wrote the terms of reference, we chose the right people, and we made them practice new evaluations over 3 years because you also worry about the faculty. So if you all of a sudden July 1, 2017, you throw everything at the faculty and said we need you to assess through a different software, different group, different work. I don't think we can sell that to them. And then the academic mentoring, which we tried it with the traditional cohort. So this committee gives a mentor to each of the trainees, and they report back to us. The committee sends me a report twice a year about the performance for each residence, and then they also recommend actions. If we see someone in trouble, we send back to them a request to have a plan, and this committee shifts to the coaching job. The academic curriculum, again, this is a half day. It's very complex. We have so many speakers. We have more than 150 lectures, and they're changing every year. It's a lot of work, so we started this. And since we're making a lot of changes, and nobody knows how the CBD will shape up, we created the Quality Improvement Subcommittee. This has nothing to do with the clinical quality improvement. This is educational quality improvement. So they watch us, they see the progress of the things we do, and they report back. This group, they report back directly to me, and then we filter the challenges. We involve the CBD lead and make changes and as we go. And we have the selection subcommittee. It doesn't stop there. The Royal College decided as part of the CBD that they have to have competence committee. And we were lucky because the competence committee structure, they said you have to have the evaluation people and the advisors to present the CBD residents to the committee in order to promote them. So we already had the academic advisors, we had the evaluation subcommittees, so we already had 2 members in the committee. The program director is not allowed to chair it, and we chose somebody else. And we have a CBD working group as well. So you can structure it according to your needs. So I did this according to my own needs. So other programs did it differently. So this is not the magic format. When you have resident, don't choose the resident members. Let them be chosen by their peers. They serve as the link between you and the residents group. And whatever you do to get close to the residents, they still fear the program director. They still don't like to be to disclose everything to you. I don't understand it completely, but this is a fact we have to do to deal with. And also, what I've done is, any decisions in the residence program committee, I ask the residence representative to present it to the residents. This way, they feel that okay, their peers represented them, they discussed it, and now they hear from them about the decision. And those residents, take care of them. These are the future of educators. And there was a question this morning about the program director. You know, if the people switch to the program director day one, do they have to have training, workshops, or there was that question in the morning. And one of the things as part of the long-term process is to train these people who were sitting in the committee. They could be future program directors. They learned. The other way which we do it in our side is we know who's coming as a program director a year ahead, and we bring them as associate program director, and they sit in the committee and learn the skills for 1 year. So this way they have a true 1 year workshop when they sit beside the other program director. So it's another way to do it. Royal College also prepares every year a new program director workshop, and the university. Feed your subcommittees with as many faculties and residents as you can. So those subcommittees in the bottom I showed you, I have about 15 faculty and about 11 residents there. And they feel they're part of the decision. So this way they can represent you because they were part of the decision. Keep your group together. There's a lot you can do more than work. Empower them. Socialize. We go for dinner sometimes. Sometimes we shift our meetings and go somewhere. The department is usually generous, and instead of doing it, you know, in the usual working hours, we just go to a restaurant and discuss things. This way, they feel a little bit different, and they feel appreciated. Defend them. Whenever it comes to my members, when they have clashes with the leadership, or I try. If they're, of course, if they're, you know, I feel that they needed to be defended, then I take it from there. This way, they don't have to involve with the politics in the departments. But hold them accountable. So make it clear in your terms of reference, job descriptions, that this is what they need to do. If you decide for action items in the minutes, you have to follow up. They have to close the loop. They have to get back to you. Again, encourage them. I send them the workshops, you know, available in the universities. I show them, the other side of the leadership, which is how to learn crucial conversations, conflict resolutions, and so on. And don't skip your representative. So if you have a site coordinator who deals with specific issues every time, and for some reason somebody skipped them, don't go back to your site coordinator. Don't deal with the issue. This way they feel that they are in charge and they're really contributing to the group. Refresh your committee again. We talked about this. And this is the succession plan. So I knew who will be coming, and believe it or not, so it's since 4 years. So somebody was really interested. We brought them as associate program director. Till last year, there was unexpected things happened, and then didn't work. So I lost that person we trained, but we had time to train somebody else to take over from me. To come back to terms of reference, they wanted me to give you some background about terms of reference. There is no magic format. If you go on Google, you will see tons of formats of terms of reference. And again, as I said this morning, choose the ones that applies to your environment, the things that you really need, and write them clear, and consult other people. These are, they have the accountability. They have the you may need to go back to them in some of the situations. So involve other people with experience when you write them. So, but in general, you have to have a background and the clear idea about the membership of the group and the expected deliverables, timeline, and who they report to, and define your quorum if you decide to go with voting, which usually we do. And then from time to time, review them. It's like the goals and objectives. The Royal College wants us to, per the accreditation standards, we review them every 2 years. So I give it to subspecialty every 2 years. They review them, approved by the Residency Program Committee, and we change the date at the bottom of the goals and objectives. The same thing. Make them available. Everybody can see them. Use the general standards of accreditation, as I said. So if the general standards say you have to have representations from all sites, write it down. In the terms of reference. And another thing in the standards of accreditation say the committee has to meet regularly, at least 4 times a year. So you have to write that in the terms of reference. Another one, that it has to communicate. You have to come up with ways that you show those accreditation groups how you've done that. You can't say just, yes, I talked to them. Yes, I spoke with people about decisions. And identify the non-voting members. I think Dr. Saud mentioned a good point there. The chair, they do, unless you have someone who's really interested in education, but they do care about the clinical side more than the education side. So they can be biased. So they attend the meetings, but they don't vote. Running your committee, how to schedule them, make it easy. These are more operational hints and tips. If you have, every 2 months in certain places, or as we said, you can take them somewhere else just for a change. And pay attention to you're just a small piece in the big picture. Pay attention to the other department or the department landscape, because your members are probably members in other committees and they do other work. So just pay attention to that. Respect time. And I look at there are busy times in the year, so we avoid CARMs, we avoid the accreditation, and we avoid the promotion meetings. Those times we avoid try not to meet as a group there. Developing the agenda. One key point: don't overload the agenda. The first thing I see when I see a 2-page agenda, I just say, okay, am I going to attend? That's my first question. Is I going to attend or not? Make it specific. There's a lot of things you can do outside the meeting. You have to clarify and make it clear in your mind, what do you want the committee to discuss, okay? Always put the important items first. People get tired. Most of our meetings are after hours. And I do this. I give them room to, if there is anything happens since we sent them the agenda and somebody forget to email us back about new items. And I have short reports, not more than 5 minutes, from all the representatives. So the site coordinators, the simulation guys, the research people, and the residents also, they provide us a report. Unless there is a big issue, I'll try not to allow it more than 5 minutes. And then again, allocate time for residence report. And you will face big problems sometimes, or there's an issue that it can go on and on all night. So if there's something you can do before the meeting, discuss things with the stakeholders, or prepare, limit the actual presentation that's going to be presented in the meeting. You do that before that. And make sure you send the agenda far enough in time. And avoid sending more emails. People now very dependent on emails, and they hate just seeing 100, 200 emails. So be specific and group everything in one email. And this is more also important for program administrators. That's why I shared this slide again this afternoon. Managing the meeting. So preparation is critical. Prepare for the meeting. Pay particular to items that needs decision. So invest more time before the meeting and how you're going to run the flow within the group. You can invite people from outside the committee if there is something you think is they bring something valuable. Sometimes the subcommittee leaders, they come and visit us. We put them first. They talk, we discuss, and then we excuse them from the meeting. You will have some members a little bit more vocal than the others. Some members, they like to dominate in the meeting, and it's your role as a program director to balance the discussion within the group. So it's not bad to have someone, you know, who likes to engage. That means they're interested, but you have to be careful. And encourage people to bring new ideas. The medical education, one of the things that really amazes me about it is there's a lot of room for creativity. You can do a lot of things, and research and education is still underutilized. And of course, ensure that everybody is respectful and collegial. And again, this is just a repeat. Make sure that the big issues are dealt before the meeting. And there is one thing, the accreditation, that you have to show the group that actually your meetings are effective. You're not just meeting. So you have to show them that decisions that were made at the committee that made a difference. If somebody discussing an intimidation issue at the committee and you came up with the plans, and you discussed with other parties, you have documentations, you followed your intimidation policy, and so on. Just an example. Have a retreat. This is one thing I found it very useful. When we started the CPD, we have a full day of post-grad education retreat within the department, and we brought every single leader in the department. So the subspecialty coordinators, the residence program committee members, the clinical leadership, the QI, and everybody. And we sat everybody report about their performance, about their challenges, and how they see their performance in the context of the CBD. Making decisions, there's no magic way, it's more personal skills, but there are a few things that you can help you. So the consultations, I'm repeating this almost for the third time. Do some work before the meeting. This, you'll find it very helpful. And then let them know that there is some important things that we need to discuss, and they're very important. And if you think there's this is probably one of the rare times you can send supplement. They send more additional information or attachment with your email if you think it will help them with a decision without being biased. Meeting minutes, they're proof of the meeting, and I've seen some of the accreditation groups, they usually get caught in the details and they actually read the minutes, which is not very advisable. Usually the people should look at the big pictures, but whatever you write there can be read by your postgrad medical education and the university, or whoever is on top of your residency program committee or the accreditation group. There's no magic format. Usually we let the program administrator to do that, to write the minutes. And don't write 5-6 pages of minutes. So not every word said within the meeting it has to be written. Okay, so that's why we usually, program administrator and myself, we go back and forth and edit the minutes. We try not to exceed more than 2 pages in long meetings. And label the action items and put names in front of them. Make people, and if you can have a timeline. So okay, this person will look after this action items and will report back to us with next meeting, for example, or so. Review the action items every meeting. So when we start, we say, okay, these are the previous minutes, and this is what we discussed, and give them an update. And circulate the minutes. There are many ways to circulate the minutes, but you have to be careful with the residency program committee. There are a lot of confidential information and decisions, and over the years there was a lot of debate how much you disclose to others, and we ended up by having 2 versions of the minutes, so 2 drafts. One is sent to the program committee, it has confidential information, and the other ones are without the confidential and sent to everybody. And this is what we talked about at the start. Let the residents communicate with the group, with their group, about decisions, and documentation is the key. So you're doing tons of work, and you will lose track of things if you don't document what you're doing. Pay attention to the number of emails and phone to the members. They're a busy group. As you said, when you respect their meeting times, it's the same thing. So don't just feel free to email everybody and phone unless you need to. And not all issues has to be communicated to the RPC. There is a lot of things you can do by yourself as a program director. You don't have to communicate everything. And if one of the members come up with a serious issue, respond very quickly. Leaving it sometimes makes it worse. Maintain confidentiality, as I said, we talked about it. Again, if you have too much work, share resources, delegate tasks, have priorities, discuss the most important things first, and then this is the hardest part, how to manage the time when it comes to you and your members. I don't think I have a magic answer when it comes to time. Provide feedback to your committee. They may not ask you about their performance, but do it yourself. Okay, so one thing I do, which I like, is I send anonymous surveys. I have a free website, Surveys Monkey. I have 1 page, and I send it to the residents sometimes. I send it to the committee members, and just see how they feel about the work, about the meetings, about the communication between each other. And it's unbelievable how much I receive when people try to talk to you without writing their names. Same thing for residents. And if I have decisions, I also sit at the department council. So those decisions, I let everybody in the department council about the residency program committee decisions. And again, this is another, the simple surveys. We have the QI also group, who's also doing an excellent work. And this is my final slide. If you missed anything, this is one of the good books you can find for program directors, and you will find a lot of things I used today from this book in addition to some of my own tips. I'm not advertising for the Royal College, but I really used this book. I was one of the first people to have it. I think it came 5 years ago, and it's very valuable. There's some chapters about how to deal with residents in difficulty, how to run a committee, and so on. And thank you.
Thank you very much, Dr. Arif, and we'll leave the floor open for 1 or 2 questions, only for the sake of time. So if you have any questions, just ask for the mic and introduce yourself and ask your question. Any questions or okay. Then in case if you have any questions, just we can find Dr. Arif during the break time, for the coffee time around 3 o'clock, and ask him that question. So we'll proceed to our second lecture, talking about the role of the residency committee. It's my pleasure to introduce my transplant friend, Dr. Riyad Al-Sahali, who is the consultant internist and nephrologist and transplant nephrologist at King Saud University. He's also the director of the postgraduate medical education. He's the vice president of the Saudi Scientific Board of Internal Medicine and the chairman of both the local training committee as well as the internal medicine subcommittee. So Dr. Riyab, while he gets his slide on, he's going to talk about the role of the residency training committee.
So I just switched. Sure. Okay. طيب. افترض ما تحرك. السلام عليكم. مساكم الله بالخير جميعا. I would like to thank you, the organizing committee, for the invitation, and I'm going to talk about what Dr. Saud Shnefi spoke about earlier today, about the role of program directors and how important and critical their role in the whole postgraduate educational system. My talk is not about the residency training committee. Dr. Arif just gave us a very nice lecture on the residency training committee. What I'm here to talk about is actually, let's see together why the role of program directors is critical and essential in this whole process. So let's learn something together, and stop me at any point if you want to have any question. I usually like to conduct these sessions in a small group round table type of sessions, just to facilitate the interaction. Okay, so the objectives of my session for today is to have an answer for these questions that you see right now. What does a program director actually do? What does a program director need? Common challenges, and how to set up your priorities, and what is your role with regards to your institutional postgraduate department or academic affairs, and the regional supervising committees or scientific committees. Okay, so that's the question that I asked myself a few years ago when I was appointed be a program director of internal medicine. It was a surprising offer, shocking offer, and it left me with perplexed for a couple of days until I said, okay, I think probably I have no choice, but I would say yes, and I will take it over and see how it goes. Unfortunately, there is no manual, except probably for the book that Dr. Arif just showed. But we didn't have a manual to guide us through, and just to teach us what our role is and what's expected from us. So I'll share some of what I have learned over the past few years. Okay, so because the program director role is very critical and it's important, it just shows you how much a program director needs actually to do. He's a clinician. He's expected to provide some clinical service to the institution that he works for. He might be required to have some academic involvement as well if he's in an academic place or like a university. He does a lot of things. He manages the program on a daily basis. He comes up with solutions for conflicts and problems. He advises these trainees. He's their big brother or big sister. They come to you. They ask for counseling. They ask for directions and advices. They look up to you. Your trainees look up to the program director, and they expect him to provide them with some guidance. And after all, or before all, he's a good communicator. He communicates with other departments within the same institution. He's expected to communicate efficiently with other program directors, either in the region or outside the region. So as you can see, he should be, or she should be, the perfect multitask person that can do a lot of work. Okay, so if we put this diagram, and I'm sure all of you, most of you are familiar with this nicely shaped flower. These are the CAMMED roles, and the program director job perfectly fits all these domains, either the medical expert domain or the other intrinsic roles: professionalism, communication, collaboration, leadership, health advocacy, and scholarly. So it all fits perfectly under the or within the CAMMED's flower. With all of these expectations comes the huge responsibilities. So you got responsibilities toward your department that owns the program. You have some responsibilities towards your academic affairs or postgraduate medical education, and you also have some responsibilities towards your own program. So let's see. This is how I divide them up, and so let's start with the first one, which is the basic role of a program director within his own program. Okay. So I expect them to come down nicely, but I'll just okay. So what's expected from a program director is basically develop your educational plan, develop your curriculum map of the program. It takes a lot of effort to do that, and most likely you'll need some help from other members of the department. The good thing that the Saudi Commission has developed a lot of manuals for each program, so the program director can just refer to these manuals and see what the educational plan is supposed to be, and work on it and develop your own curriculum in line with the Saudi Commission requirements. You're expected to develop and chair the residency program committee that Dr. Arif just spoke about. You're expected to monitor your trainees, monitor their evaluations on a monthly basis or on daily basis even, for those who are in difficulty. You're expected to identify those residents or those trainees who are in difficulty. These are very important people that we, for the most part, we fail to identify these people earlier in their first years of training. So we end up with a lot of problems that accumulated over years towards the end of their training, and that might be reflected on their performance on the certification exams eventually. You'll be expected to do a lot of career counseling to your trainees, and these are typically conducted during your either annual or semi-annual meeting with your trainees. Those who are towards the end of their training, they're it's not a requirement, but it's some sort of an expectation. It's more of a cultural expectation here that the program director should work on some exam preparation for those who are board eligible or just about to finish their training, and meet with your residents very regularly. Try to make it a habit. If you have an assistant or you have a deputy, you could probably divide up the meetings between both of you, especially if you have a very big number of trainees. But meeting is important. It gives you a chance to learn more about your trainees, and it also gives your trainees a chance to learn more and know you at a closer level. Okay, continuation to the responsibilities towards the program. You're also expected to participate or develop a policy or a procedure to select new trainees, and that's usually conducted through your training committees. Try to be available as much as you can. I know it's challenging. People sometimes find it frustrating when a trainee might send you a text message or an email on a weekend. If it's not an urgent matter that you need to respond right away, you could delay your response, but try to be available. Try to show them that you're always there when they need backup. Keep your records. one of the major defects that we usually see when we accredit or re-accredit a program, that the documentation is missing. The meetings or the minutes of the training committee is lacking. Counseling sessions are not documented. So if you don't document what you're doing, basically you didn't do it, right? So try to document these things, especially when you know, the at least at the milestones of at certain milestones in the residence program, either at the end of the year or when you do your annual or semi-annual meetings. If there is a problem and you bring the resident in to counsel him or counselor, try to keep these records, because this is the thing that you will go back to a couple of years or a few years down the road when there is a problem. So you usually go to your records and retrieve the relevant information that you documented. Try to know your institutional postgraduate policies and implement them. Most of our institutional policies are somehow in line with the Saudi Commission regulations and policies. Maintain the standards for Saudi Commission accreditation, because this is something that you will be subjected to do maybe once or twice during your post as or during your term as a program director. But know what's required and try to make sure that these requirements are kept or maintained. If you have a chance and if you have the enough resources, developing an evaluation system for your faculty or for your consultants is always helpful. It's helpful for you, it's helpful for your trainees, it helps the faculty or the consultants, and it also helps the chairman of the department. We always do teaching, but we don't know how that teaching has been perceived by trainees. It would be always nice to see how you're doing, so faculty or consultants can work on improving their teaching skills. Okay, so these are the responsibilities that I could summarize towards the program. Now, let's see what the responsibilities or the expectations from program director toward the department. And Dr. Saud al-Shanafi earlier today touched base on the relationship between a program director and a chairman, and how things can be very smooth, how things can be very not smooth. So there are fine line between the two positions, the chairman and the program director, when it comes to trainees. Let's see what we can say here. So, if possible, whenever possible, try to have the chairman of the department on your side. Maintain a professional relationship. Sit with them, inform them of how the program is going, update them with any updates that comes from either the postgraduate or from the Saudi Commission. So try to work in harmony with your department, because that will facilitate a lot of whatever plans you try to implement in order to improve your program. Communicate relevant information to the department members, either consultants or faculty, especially when it's something related to the residency program or the fellowship program. And engage your faculty, engage your consultants in the curriculum. Ask them to teach, ask them to provide some bedside teaching. Have some reward system. Sometimes, like at the end of the year, just a small appreciation letter to all faculty who participated in any level of teaching is highly appreciated, and people receive it very well, and it just reinforces their positive attitude toward residency or towards teaching, and it's something I found it personally very, very useful. And whenever there is high-profile issues, especially when it's affecting the clinical service, either the number of trainees is being cut or the number of trainees is being increased, your program is somehow might lose the accreditation because of some critical issues that are happening in the department. Please bring them up and discuss them in the department meetings. Okay. Now, towards your institutional academic affairs, few things. If the academic affairs conducts, and they're expected to conduct regular meetings or board meeting, you have to attend these meetings to first to know more about your own institutional regulations, to get to know other program directors, and it facilitates the collaboration. Implement these postgraduate policies and issues that are related to your training program, either resident related or just overall program structure related. Bring them forward for discussion and get the help and the backup from postgrad. Okay, whenever possible, try to participate in any institutional internal reviews. If your institution is conducting internal reviews of any of your programs, please participate. That will be a great learning experience for you, and you can actually reflect on your own program. Okay. Now, so we spoke about what the program director is expected to do, and the responsibilities of program directors toward their program, towards their department, towards their institutional academic affairs. Now we have the other regional committees that you might need to report to. If you have a regional committee, a supervising committee, and most programs do, try to attend their meetings, and you're usually a member of those regional supervising committees or the scientific committees. Meet with them regularly, get to know other program directors. They will help you to facilitate a lot of the logistics, especially when it comes to exchange of residents or filling the gap in your curriculum. And you can exchange experience with other program directors, and that's when you're expected, in those committees you're expected to submit your annual promotion results for approval. Now, one thing that I would advise you to do, try to communicate with these local committees through your academic affairs or postgrad. It's not nice. Because I've been on the two sides. It's not nice when a program director just approaches the regional supervising committee and your academic affairs or postgrad is the last to know about it. It's better just to have things channeled through your postgrad or academic affairs in order to reach the regional committees. Okay. Now, what a program director needs. Given all these responsibilities, we expect program directors to need a lot of things. I would just summarize a few things that I think very essential, and I would actually like to have them in any accreditation checklist. Okay, I think we all agree that a program director, in order to do all of these expectations, at least needs an office. You'll be surprised how many program directors do not have their own offices, and I think it's a mandatory part of any accreditation checklist that at least an office is secured where the program director can do his own job comfortably, and that's where the records are usually kept. So an office space is needed, definitely needed. That we're just talking about the basic needs. Now, the second basic need here is the administrative assistant or the secretarial support, and that depending on like how big your program is, but you need at least someone who's capable of writing letters, capable of sending emails, receiving emails, communicating with other departments in order to facilitate the whole process. If you have a larger program, you're probably expected to need more than one. But that's something that I personally think is necessary in any accreditation survey. Okay. The third one is someone to help you, someone who can officially help you in running the program. A program, you can call it a deputy program director, you can call it a program director associate, someone that you trust in your department, not necessarily your specialty, but at least in the department, who can help you do part of the assessment, help you conduct exams, help you meet with the trainees. It's always useful. I know it is not a mandatory requirement in any accreditation checklist, but I personally think it's important, especially for larger programs. Like when you're supervising more than 30, 35 residents, or even some programs like medicine, the number might exceed 80 or 90, you need someone else to, or someone with you to help you run the whole thing. Okay. Now we have challenges, and the challenges are a lot. Some we can overcome, some we cannot overcome, and we just choose to live peacefully with. Okay, so one of the common challenges is lack of admin support. It's common. I don't want to quote numbers, but it is a common problem that we face when we do the re-accreditation visits. Some program directors do not have the adequate or the minimum knowledge of the policies, either the institutional regulatory policies or Saudi Commission policies. Now, the good thing that most of these policies are actually available online. Pull them up, read them, educate yourself about these regulations, and that will help you and protect you from doing something that is not totally correct. Something that we face almost on, I don't know, but regularly, uncooperative faculty or uncooperative consultants that they don't want to participate in teaching or providing supervision to your trainees, and that's part of what the postgraduate should. That's where you need the postgraduate to step in and help you. Intrusive chairmen or department members. Sometimes they all think that the program is their program and they want to intervene with your decisions. They might intervene with the either called schedule, rotation, master rotation distribution. The number of residents in this specialty is not enough. Please, we need more here or less there. So these things are there, and that's where the governance of the postgrad helps a lot in outlining what the program director has the authority to do and what the department chairman has the authority to do. Overwhelming operational work, especially if you don't have adequate or competent admin assistants, and something that we face, I think, at all levels, whether you're a program director or not, that you don't have enough time to run things. Okay, demanding residents, and usually these are our main clients. Sometimes one resident can occupy 90% of your time just because of their ongoing, recurrent, or repeated problems, whether academic problems or professional problems. So that's another challenge. Okay, so with these challenges and these responsibilities, we have to survive. We have to get somehow a way where we can live with all these challenges. So set your priorities. Try to create your time. Protect a time for you in collaboration with postgrad, in collaboration with your department chairman. So that time is protected where you can actually run and operate your program, either half a day a week, 2 half days a week, less clinical coverage or clinical requirement. There is no black or white. There are no right or wrong here, but you need, program directors need time. And whenever you have these, lack of time, a lot of demands on you, take care of your program backbone first. Get your master rotation schedule fixed, on-calls fixed, and monitor your evaluations and don't miss them. So these probably 3 components are major for any program to stay alive. Once you mess up with your master rotation, once you start missing all these evaluation reports, your program can fall apart. Get help from your department members, and select or wisely select a chief resident, or maybe more than one chief resident. They help you. They can take a lot of work on their shoulders. You can discover a lot of leadership and skills in these young physicians, and they can make your life a lot easier. The larger the program, probably more chief residents are required, but they're valuable, they're helpful, and they always come up with things that you never thought about, and they're very close to residents. They can deliver probably a more transparent feedback to you than anybody else. document everything whenever possible. Document your progress, document your meetings, document your committee meetings. Those who are residents who are very demanding, or those who are in difficulty or facing difficulties, try to document the progress that you're doing with them, and run your RBC or training committee efficiently. And Dr. Arif spoke about that. As much as you can, try to be available. Now, this might sound very ideal. I know the challenges are a lot. I know what our system has, and I know where the defects are. But after all, program directors, to me, are the cornerstone in the in any post-grad education system. They make programs, and they can break programs. But I think from my own personal experience and from my dialogue with other colleagues, it's a very rewarding job. After all these challenges that a program director might face, it's very rewarding. Being part of someone else's professional growth to me is priceless. When you select a resident from med school and you train that resident until that resident graduates and they come back to you competent, they can actually challenge your own clinical decisions. To me, it's the best feeling in the world. Okay, that's all I have to say. Thank you.
Thank you very much, Riyad. And now it's time to take questions. Can we get the mic here?
Thank you for this beautiful lecture. Every time I listen to it, this is the second or third time, I learn something.
I don't repeat things. How am I?
You don't. You add things. Seriously, it's really beautiful. Now, as a regional director of otolaryngology, what about if you have a difficult program director? Not a difficult resident, not a difficult consultant, really a difficult program director, who is not supported by his team, who is a lot of complaints from his residents, and the department is not willing to change him, or the administration is not willing to change him.
So, Doctor, thank you for your nice words. So you're talking about you being the chairman of the regional committee,
yes,
or the postgraduate director?
No, the regional committee. Okay. The regional committee.
Saudi Commission.
Regional committee.
Okay.
Yeah.
So it's challenging because you're not the one who hired this program director in the first place, and you don't have a lot of governance on him. صح? It's challenging. Wrong answer here. Lakin, I think you as a chairman of a local of a supervising regional committee, you're expected to report to the chairman or the president of the scientific board. صح? Okay. So that's something in your hands. So if you recognize a program director with all of these issues, and where the professional relationship with this person is becoming difficult, or you reach a dead point, I think that's where you need the scientific board to step in and help you and provide you with some support, because after all, you belong, or you report to the chairman or the president of the scientific board. So I think one of these, alhamdulillah, doesn't happen very often, but when it happens and the work environment becomes very unhealthy, or sometimes the program director is nice and everything, but totally incompetent. They have zero awareness of what they're expected to do. They don't have to be stubborn and difficult, but sometimes they're just incompetent or careless, right? They're nice and everything, but they're not doing what they're expected to do. I think your role as a chairman and the person responsible for the functionality of that, or the operation of that committee, is to report to the scientific board all these concerns, and that's when the recommendations might come to replace that program director, right? Yeah, thanks.
Thank you.
We have a question here, Saad, here.
Work?
Yes.
Yeah?
Now it is.
No, no, I just want to comment on the situation. I think it depends on where is the issue here. If it is something related to residents, and the committee at the Saudi Commission is sure of these events, probably the officials of the Saudi Commission should communicate with the academic affairs directly with these issues. And after investigations, if the academic affairs are not convinced, then they have to redo it. And if they are convinced but they're just refusing to do it, then it has to go to the the commission itself, because in the bylaws, I think, of approving programs, one of them is to have an efficient program director. So if you have the evidence, then the committee has the power to suspend the program. And when this language becomes at this level, they will respond.
Okay, thank you. Can I take my...
We can see.
Yes.
Oh, it's in the back.
Thank you.
So this is the last question, then we'll proceed to the next. Go ahead.
Okay. Program Director, National Guard Psychiatry Al-Hassa. I think my major killing is the Saudi Commission itself. That's always my problem. And my problem is in 2 points which is face me all the time. The first one is the lack of a system where any consultative process between the program director and the Saudi Commission is completely absent. We end up hearing about new policies, new changes, but without any form of consultation where we would be able to give a feedback before this decision or that policy has been changed. So lacking of this system is definitely all the time you feel as if your expertise or your experience you build is being undervalued and you're not being appreciated and did not help. That's my first point. The second one is budget. I am a member in the regional program committee, and we're expected to have a weekly training program for our residents without any fund, without any budget. And from where we can do that? So nobody will be able to, you can't go to anywhere. The Saudi Commission has got no resources to help you, to support you to be able to run your academic program, but at the same time it is a mandatory requirement you're expecting to do. And unfortunately, because lacking of that level of communication, you will end up in a limbo. Thank you.
Well, thank you. First of all, I don't represent the Saudi Commission. So, okay? No, I'm just joking. No, I'm just joking. So, Doctor, your first point was that things are being, or decisions are being taken at the Saudi Commission level, maybe at the, you mean probably at the scientific board level, or at the admin level, like from the executive office of training, and program directors are not being informed, or you mean involved? Involved. Well, the involvement, I think it might be challenging from a practical point of view. How many program directors do you have, and how many decisions do you need to make? So the involvement are usually taken, like the regional committees are just samples of the program directors that we have in the region or in the country. So usually, from my own modest experience, that the voice of the local committee is usually heard and the opinion is taken. It's usually the responsibility of the chairman of that regional committee to communicate with the members of that regional committee and discuss and come up with consensus on an issue. So I'm not sure how much involvement all program directors need to have in order to make these decisions valid. I know that there is probably not very optimal communication and information of all these new changes to the program directors, and it's variable from one specialty to the other. Maybe medicine or surgery is doing really well, other specialty is not doing well. So we know that there is probably suboptimal communication in there. Now, with regards to the second question, where you're expected to conduct some academic activities on on certain intervals, but you don't have the backup. You mean the backup from the Saudi Commission? You mean logistic backup or logistic backup? I don't know if I'm in the. I don't think I'm the right person to answer this question. Probably to Samuel Haider will be the one who can help you with that, because I'm not sure what would be the best action here. But I would usually recommend the usual chain of of communication, where the regional committee chairman reports to the scientific board can report to the executive training department, and then where the things can be solved. Each scientific board has a budget to dispense on all of the educational expenses, like the mandatory academic activities. We know that fund is there, so but it's, I'm not going to be the person who speaks for others.
Thank you very much,
Yeah.
Ed. If you can direct the question to Dr. Samuel Haider. I will be back here in the afternoon. He is giving actually the last session around 3:30. So any question related to that topic can be directed to him. Now we're going to proceed to our third and last lecture for this afternoon before we break off for coffee at 3 o'clock. It's my pleasure and honor to introduce Professor Susan Day. She's a pediatric ophthalmologist, and she's the senior vice president of ACGME International. She has previously served the ACGME in various capacities. Without further introduction, I'm sure we're going to learn all from Dr. Susan Day about the international standards of the training programs.
Thank you so very much. Assalamu alaikum. May I start, please, by complimenting you, the audience, with your attentiveness. It's been a very long day. You probably had a busy day yesterday, and you probably have many more things to do when you leave today. Nevertheless, you're still here, and I'm grateful to have an audience. It's a pleasure to be here. And this last section will be a blending of sort of philosophical elements as well as pragmatic elements. I've been asked to address what is occurring in the rest of the world, and specifically how the rest of the world is viewing standards for medical education. We've had some questions throughout the day of what does Singapore do, what is happening in China, et cetera, and you all know from training your students how curious everybody is about the state of events throughout the world. I come at this from the position with the ACGME International. That's a subset of the parent organization that's only been in existence for 8 years. So we're in a way a bit of a startup company, but it's really my pleasure to represent them. To help you understand where I am getting the material that I'm talking to you about, the majority is in fact from that role with the ACGME International. But I started as a program director, just like you, and enjoyed it so much that I stayed for 20 years. I was frankly at a point where I was starting to become a grandmother and having children of the people that I trained initially. And I thought it was perhaps time to leave and let someone else do it with a fresh eye. It's also very important, as I hear what you say about wanting to make things better, that now in your role as a program director, you have the opportunity to input as a volunteer the very important process of setting standards for your own specialty. So I did volunteer work really on the weekend while I was a program director and a clinician. And then finally, I'm coming back to a place that I enjoyed living here about 30 years ago. It's hard to believe that. But I spent 14 months at King Khalid Eye Specialist Hospital in Riyadh and certainly enjoyed it. And I'm astounded to see all of the changes that are occurring in your country. They're beautiful. I've been asked to talk about various aspects of international standard setting. And to start with, why are standards necessary? That's a very fundamental philosophical question. should standards be international, or should Saudi Arabia have one set and the UK have a different set, and so on and so forth. I've also been asked to address how we ensure that there's compliance with these standards, and what standards are difficult to meet from a very pragmatic standpoint in your own programs, and then how you as program directors can address some of these deficits that you see in your own program or with your own residents. So let's start with a picture that isn't exactly what you were expecting to see. I'll tell you a little story. This is a building where people are on the outside and they're communicating to people on the inside. Now, what do you think is going on in that building? Exams, bingo. And this is a building in India, and inside the examinees are trying to get into medical school. And I guess they must have had to leave their cell phones at the desk, because they are in fact getting answers from these people on the outside that are handing them in. Now, if anything ever needed standards, it would certainly be standards to prevent cheating for a medical school entrance examination. But what this also says is how important our profession is to others. I know that here in Saudi Arabia there are many more people who want to become physicians than ever have the opportunity. So here we are with a huge responsibility of making sure that those that do get in get a proper education. Your country has also defined the importance of a strong education and has as one of its 2030 goals to enhance the standard and quality of health care. And as we've heard already, this is both a qualitative as well as a quantitative need to increase the physician workforce in your country. In order to do this, having a system of education that produces in a mass manner, a mass production of quality physicians. That's what you're looking for, and that's what the Saudi Commission is assisting our educational system with doing. It's not advancing. Does that mean it's a break time? Would someone be able to help me out? I think I got it. No?
Is it working out?
I'm not sure. I think it's trying to tell me something. If the AV assistance is there, I'd appreciate it. If not, let me try another way.
Can we get some help, technical help here?
While we're getting help, I can tell you that the next slide addresses why our standards necessary. We've heard a lot already about why standards are necessary. Certainly standards are necessary in order to define what it is that we need to teach. I'm just not able to advance.
Oh, okay.
Thank you. So producing quality physicians is absolutely one of the key points in why we need to have standards. We also need to improve the quality of care for our patients, and we improve the quality of care of our patients educationally not only for the patients that are served today, but also for the patients that are going to be in that trainee's career 20 and 30 and 40 years down the road. So that's a tremendous task. We cannot teach everything that they will be faced with in 30 years, but we can teach the style of judgment and the approach to a disease or to a clinical problem that's so essential. I would also say that the middle point of defining responsibilities and who the responsible parties are is a very, very important aspect to standard setting. Why is it then that we have this immense burden of standard setting now? Well, obviously a lot is going on. We can no longer live with the mentor and apprentice model where one person is responsible for all of the education. There is too much knowledge to do it that way. We need a system. Secondly, the world moves around. I would guess that most of you have lived some other place at some point in your life or might in the future. And our patients come from different cultures, and so a sensitivity to the people from other parts of the world is very important for a physician of today to have. Disease demographics change. We have so many McDonald's now, and you know what that does to diet and to disease demographics. In fact, there is apparently a one-to-one correlation between the number of McDonald's in a country and the incidence of, or the prevalence of diabetes in a country. Now, obviously there are other factors, but the point is there's a blending of disease demographics, and countries increasingly are faced with the same problems that their physicians must cure. And then finally, the rapid technological advances are doing several things. It's making communication with the rest of the world much easier, sometimes to a fault, but it's also requiring that we learn how to adapt these technologies in our own practice. It's also important to look at what happens if we don't have standards. And we were really good at no standards in the United States over 100 years ago, when anyone could say, I'm a doctor. And trust me, just take this potion and you will be cured of diseases A through Z. Well, obviously that led to an absence of trust by the people, and that was the direct consequence of creating the Flexner Report, which revolutionized medical education in the United States. Let me backtrack and just mention that in China, there is a huge spread in the quality of physicians. And this, too, leads to an absence of trust because there's not a common product. And society judges how good physicians are in a country, not by the best doctor, but probably by the worst group of doctors. As a consequence of this limited trust in China, there is a preponderance of patients or their families who get angry, physically angry at their physicians or their nurses or other people involved in the healthcare team. In one of my recent visits there, I had a medical student helping me navigate the hospital, and he told me that one of his classmates had been murdered by a patient's family. The one that was murdered had not been involved in the care, but was simply standing and watching the bedside rounds when an angry relative came up and stabbed the person. Now that's a pretty serious problem, but it's all a consequence of an absence of trust. I'll move now to try to talk about standards as opposed to accreditation. We tend to use these words interchangeably, but I just wanted to stress where, at least in the mindset of the ACGME International, when we use accreditation, we're meaning much more than standards. In specific interpretation of accreditation within ACGME, we are talking a system of education which is peer-driven in its derivations. So the pediatricians will have representatives who will decide what the standards or accreditation rules are for pediatricians. Same for radiology or dermatology or family medicine. And this peer-driven process is predominantly a volunteer process, where those who are setting the rules aren't being paid to do this work. And it's not the ACGME which so much sets the standards as it enforces the standards. So it's important to understand that an accreditation process that's solid really needs to hear from the constituents that are practicing physicians. Another important concept is that accreditation requires that the adherence to the requirements are validated. It's not enough to say, oh yes, we do it this way, and yes, all of our residents receive an appropriate amount of clinical experience. A validation process such as you have with site visits and with reports is essential for a true accreditation process. Ideally, this accreditation process should avoid conflicts of interest. Why is that important? We're all proud of our students, and we sometimes fail to see some of the deficits in our students, which in part may be created by deficits in our own educational program. And in order to make sure that our programs are solid, it is probably best to have some form of external review where there is not this potential or even perceived conflict of interest. And then finally, one of the hallmarks of accreditation should be that the outcome is that every person who finishes your program is capable of independent practice upon graduation. That's a very important point. Now, this is really another almost philosophical question. Should all standards be the same internationally? Let's look at that a little bit. As has already been said today, there is an international body called the World Federation for Medical Education. It's a subset of the World Health Organization, which is in fact a subset of the United Nations. So it should, in principle, be speaking with great authority. We've also heard that the WHO wants to have an accreditation system so that we can start to think globally in our educational process. Yes, the WFME has developed standards, but I would contend, and they would agree, that they are not really truly accreditation. They are standards intended to be a guide. The WFME has a huge task. We've been talking about postgraduate medical education, but the WFME starts with responsibility in medical schools itself. And in fact, UME, medical school training, is now accredited through a process that's housed within the WFME. My guess is that at some day there will be a similar accreditation process adopted by them for postgraduate medical education. Let's look at their standards then, and I emphasize the word standards rather than accreditation. They state specifically that these are not accreditation, but rather they are intended as a guide for medical education programs. And they provide the responsibility for accreditation and compliance to institutions and programs. If you look on their website, you will see that these standards drill down into what an institution needs to do as well as what all programs need to do. There are no specific requirements for how many surgeries somebody in that field should do, or how many continuity clinics somebody in pediatrics or internal medicine needs to do. And their belief is that these more specific specialty requirements should be done locally. In fact, some people call this glocalization as opposed to globalization. It also advocates that when accreditation occurs, that it should be created through national rather than international bodies, very much such as the Saudi Commission is doing here. For some reason, one of the slides is not showing up, so I'll just proceed on. This is an age cartogram of how things might look age-wise, and the one on the left shows Singapore and actually has a block of the younger ages. What you would see under that red rectangle is that there are very few children in Singapore. I believe I have that backwards. Yeah, this is rather a cartogram of Saudi Arabia, where there are very few older people, and where, if you could see under the red, there would be an expansion of the number of people in your country. On the right should have been a cartogram similarly constructed of Singapore, showing a rather old population and very few children. So you could see that if you're a general surgeon in Singapore, experience in pediatrics might be difficult to obtain. So a difference in age population is certainly one aspect where standards deserve to be at least flexible, if not different, for individual countries. There's some other reasons as well, and once again, for some reason, I've got some pictures that just aren't showing up, but that's okay, we can imagine. There are disease demographics that are different. I had 3 pictures of patients that I saw at KCASH when I was here some 30 years ago, showing a baby that had congenital glaucoma, another one that had a retinoblastoma, and then finally an elderly gentleman with crossed eyes so severe that you could barely see the corneas and the irises. And so these disease demographics are so different here. In the United States, I would see very few patients that had those sort of appearances. But here I would see those every week. So it would seem plausible then that the standards for this country would require that young training ophthalmologists would see more of those diseases. Certainly there are cultural differences that we must attend to, and you've heard about some of those today. And the standards reflect a need to be sensitive to cultural differences. And then finally, standards could vary because scope of practices are different in different countries. Family medicine is probably the most common example for that, where in some countries, people that are family medicine physicians are the ones that deliver babies, and in others, they would be considered to be doing malpractice if they delivered babies. So we have to be sensitive in a standard-setting mode internationally to make sure that we have a sensitivity to disease demographics, cultural considerations, as well as scope of practice needs. So let's look at some of the positives for adopting international standards. I've already said some of these. Society moves around, so do physicians. There's a blending of disease demographics. The compliance validations becomes a real problem in small locations when conflict of interest cannot be avoided. So validation may lead us toward an international standard setting mode. And then finally, we've found that with ACGM International, when people want to do fellowships, there is a greater eligibility possibility for someone in one of those graduating international programs to attain subspecialty training in other countries. So lessons learned from the ACGMI experience. Flexibility is the key. There cannot be one set of international standards that serves all country or regional needs. Yet, the standards can be made to be flexible. That's not an impossibility at all. Secondly, what's important is that the accreditation process itself, the system of education, is exportable. We have had ACGME requirements and work in places as prosperous as Saudi Arabia, with KCASH now being accredited by ACGMEI, and as challenged economically as Haiti. So much of a good, robust educational system transcends any economic barrier. We also have learned that review committees, and I'm sure you have a different name for these, but review committees are the ones in our parlance that in fact make the accreditation system. And we have 2 international review committees with representatives from multiple different countries. And to see them make very thoughtful decisions about the accreditation readiness as well as the accreditation standards meeting. These people work hard at it, and it's beautiful to see that really medical education and quality, that's a common language, and it can be done across country borders. We've also learned that the continuous improvement model for education, such as Dr. Weiss outlined this morning, works everywhere. And I agree 2,000% that we don't want to lose any of our trainees. We just want to graduate every single trainee as being well prepared. We've also learned that improved quality of the program does lead to quantitative growth. When a program is good, they get more applications. And so if one of the goals of your country is to increase the quantity, you can certainly do that by increasing the quality of your programs. And then finally, how does ACGMEI work with ensuring compliance? Well, first of all, we define the responsibilities very clearly for the institution, for the educators, for the faculty, and even for the residents. That's really so very, very important. We also have standards that are difficult to meet, and you could probably guess what those are as well. The big one is service versus education. Well, we can't let our residents go to that many conferences because we need them to push patients to the x-ray or to draw blood. Well, obviously, when you have true accreditation standards, you're talking about the education of the trainee. And yes, it's important that everyone do some aspect of service. That's what doctors do, is they serve others. But when the burden of the task becomes so excessive that their educational needs cannot be served, then that's problematic. And it's problematic everywhere. And when accreditation comes in, all of a sudden there's a stick that will result in the switch away from service toward education. We've also learned that there's a natural human tendency to give the better resident the tough cases, or to allow that resident to see the complex patients. In fact, accreditation should and must take care of every single resident and make sure that clinical experience of all is equivalent, not identical, that could never happen, but equivalent, such that the person does have an opportunity to see all the diseases. That's very important. Faculty scholarly activity. We've heard again how difficult it is for faculty to set aside time for research. But research need not be with test tubes or laboratory animals. You can do research with clinical education or resident training. And when there is a standard there, an accreditation rule that says the faculty must do scholarly activity, all of a sudden the scholarly activity happens, and that leads to more job satisfaction. And in some regions where faculty in large part come from an expatriate workforce, as their job gets better through better standard setting, they tend to stay longer because they are more engaged with their job satisfaction. Clinical experience is something that also is a very common deficit when programs initially start out, because it's natural to pay attention to what you have with a long line at your door. But if there's a standard that says it really is important that the pediatricians spend a certain amount of time in a NICU, or that the internists follow their patients after they're discharged from the hospital, then the program's adaptations to this standard set need results in far better clinical experience. But it's an evolutionary process. Some of those deficits take time to attend to and to remediate. And then finally, the problem resident is a common problem everywhere. Think about the age of most residents. It's such a dynamic time in their life. And the problems that you may see of coming late or not studying may be related to some of the intensive pressures that they're having at this time in their life. So these standards, though difficult to meet, are very achievable once attention is paid to them. How might you do it? Well, I would absolutely say that often a weakness is noticed by others first. That's the true value of an internal review, and then an external review, and even an accreditation site visits. We all have blind spots to what we are doing in our day-to-day activities. Once a deficit is discovered, then who's supposed to fix it? And the accreditation standards really need to be very specific in directing an avenue for a responsible party so that the problem can be remediated. It's just so easy to say, oh, we can't do this because so-and-so is responsible. Well, the accreditation standards really should point to the person that's responsible. Another important point to make, given the attention to the committees, the training committees that we've heard about this afternoon, is the wisdom of the group. When all the faculty convene and start to talk about resident performance, sometimes there will be problems identified that don't even show up in any other manner, in a survey or an evaluation or in your own individual meetings. It's always important when we look at a deficit to say, is this a real deficit? Sometimes an accreditation decision will point to something that you in fact do in your program, and it might have just been a documentation problem, such as with the minutes. And then, is it important? It's an onus of responsibility on the accrediting body to make sure that their standards are still relevant as well as important. And so sometimes there is such a groundswell of question about a particular standard that it is the impetus for changing the standard to a more appropriate requirement. In essence, the standards themselves must identify a mechanism for correcting any deficits. So, in summary, the purpose of standards is to improve health by improving education. You all know that, but we really need to say it. Secondly, mass production of quality physicians is dependent upon enforceable standards. They must be validated. Thirdly, from an international perspective, both globalization, that is, common standards across boundaries, as well as globalization, flexibility and attention to your own country needs. Those are both important. Fourthly, a key function of standards is to create accountability, and there are many responsibilities. There are many responsible parties in designing and sustaining a program of education. Then, adoption of standards has led to identification of common problems. Worldwide, service versus education is an issue. Worldwide, scholarly activity is an issue, and clinical experience. And so to start conversations with people from other regions will help you feel a little bit better about yourselves and may also lead to creative decisions and best practices from others to address deficits. And then finally, The continuous improvement of education is enhanced with the validation of the standards. In other words, we must be accountable. We can't just say that we're doing things. There has to be somebody independent that comes around without conflict of interest to help you judge how you are doing and to help you get even better. I want to thank you and really, truly appreciate your attentiveness toward the end of the day. That's exceptional. It's a joy to be here. Thank you.
Thank you very much, Dr. Zaid, for this nice and informative lecture. And we have enough time to take questions now. So if you have any question, raise your hand. Can we get the mic here?
I have two quick questions. The first one, now, are you saying that the globalization here is for standards, not for accreditation, right?
Please repeat the first part of the question. I know that centers on standards versus accreditation.
Right, like I'm just thinking now about the globalization. Where do you think it's going? Is it going towards globalization of standards or accreditation?
That's a great question. And I don't have the answer. I can only say that the big boys out there, the World Health Organization, has used the word accreditation. Currently, the people that they've abrogated this responsibility to have used the word standards. If you look at what medical schools have been directed towards, it is toward the direction of accreditation, enforceable standards, so to speak. So I would guess that if the WHO is an effective organization, that we will move in the direction of accreditation. That would be my desire, because I'm a firm believer that accreditation is helpful in creating quality programs.
And the next question, just based on this answer, who's accrediting who, to be honest? Because now all these international accreditations happening based on business models from business arms of major, accrediting bodies. If the WHO now going to be adopting it, are they going to follow the same stream? Because with time, the accredited bodies now, accredited ones, accredited institutions, they're probably going to lose interest with time, especially when it becomes really expensive, and with time they will adopt these standards and they will become a commonality. So it won't be any more an attractive label that you tag your programs with. So where is this going?
I wish I knew. No one's told me. But once again, I can show you what has happened with medical schools. That is now an international accreditation process. But it's really important to understand that built into that medical school international system is a big flexibility, the globalization sort of thing. The WFME technically accredits the accreditors. So I am guessing that for medical schools, the WFME has accredited, for instance, the Saudi Commission to have medical schools. It certainly accredits the body that's in the United States that is responsible for undergraduate medical education.
Any more questions? If no more questions, I'd like to thank all the speakers, Dr. Arif, Dr. Riyad, and Dr. Susan, for these nice lectures, and would also thank you all the audience for making it on time. And now we're going to break off, and we shall come back around 3:30. Thank you very much.
أعزائنا الحضور، نشكر لكم استماعكم. استراحة لمدة نصف ساعة ونعود على الساعة 3:30.